We are live. Happy Friday.
Happy Friday.
Thank you, everybody, for being here. We have Robyn Merkel-Walsh. I have been very excited and looking forward to this talk today. So thank you so much, my friend, for being here.
Thanks for having me, my fellow classmate.
Yes.
And we're able to, stay in touch and maintain not only colleagueship, but a friendship since we trained together with Mary Billings and Diana Davidson in New York. So it's so great to see you again.
Yes, and what an amazing group we had.
We did. We had a great group, and we had a great weekend too.
Yes, just today, one of those Facebook reminders sent me a picture of it. And I was looking at everybody there. Oh my gosh, I'm still in touch with so many of those women. They're all fabulous. So
yes.
I'm so lucky that it just happened that we went to that one.
Yes. We're very lucky.
First, I'm going to introduce our speaker to everybody. And just to remind everyone, if you would like us to read your name, you can just type your name. We can see on Facebook, you guys can see each other. And later we'll be able to see your name. But right now, in the platform that we have, it just has Facebook user. So happy Friday. Somebody's very excited. I'm not sure who it is, but we have some viewers. Thank you guys so much for being here. So, oh my goodness, my daughter, I am live. Please come in here. That's
it happens. It happens. We're people. So we're people.
There you go. That's Zoe. All right. Okay, so we have Robyn Merkel-Walsh. She is a licensed speech pathologist and certified orofacial neurologist with over 2 decades of experience in the state of New Jersey. She's employed full-time by the Rotational Board of Education and runs a private practice in Ridgefield, New Jersey. How do you do it? She is a lecturer and master for TalkTools. She has been elected New Jersey Kids Top Doctors in 2013, 12, 13, 14, and 18. Robyn received both her undergraduate and graduate degrees from Montclair State University, where she was later invited to be an adjunct and clinical professor. She also taught classes at Bergen Community College and is a former clinical site coordinator for Seton Hall University. She is the board chair of the Oromotor Institute, and she's a proud recipient of 3 ASHA, is it called ACE Award?
ACE Awards, yeah.
And the Ridgefield Woman of the Year 2019 in business. Congratulations. Okay, and if we keep going, we'll stay here 30 extra minutes than we can. So here we go, Jojo. Let me throw you this. There you go. She wants some myofunctional therapy tools to take to her birthday party.
Okay.
So she's ready to the office to take them. Go ahead.
It is fun.
Yes. Sorry, I am live right now. I can talk, y'all. No, but thank you. I am so sorry. You guys get out of here. All right. Well, thank you, Robyn, for being here. Let's introduce our topic. We want to focus today on the differences in feeding therapy and myofunctional therapy. In your latest research article, which I posted that on our Airway Circle group, you stated that OMDs, or facial malfunctional disorders, should certainly be treated in infants, young children, and individuals with special needs, according to the methods of the pediatric feeding specialist. Please explain to our viewers what orofacial myofunctional disorder treatment is like in young children, and who's the best specialist to treat patients younger than 5 years old?
Okay, thanks. That's a great question. And this topic has been a passion of mine for about the past 4 years. When I've had quite an evolution in my career in terms of caseloads. So when I first started, I was working a lot with quote unquote neurotypical school age children, and I was doing a lot of myofunctional therapy. But I was also, trained by Sarah Rosenfeld Johnson and Pam Marshala and Diane Barr and a lot of feeding specialists in speech pathology. and I could really, see the overlap. But I very quickly learned early on that, when you're working with the 0 to 5 population, and I kind of delineated for Renata 0 to 4, 5 and up, and then special diagnoses or children with special needs or even adults with special needs in that 0 to 4-year-old group. And the reason being is that at that age, the true essence of myofunctional therapy, which, as you know, is a COM, includes self-monitoring and volitional execution of a motor task, right? So when you look at the difference, for example, if you come to a TalkTools class and you learn about oral placement therapy, we're using a lot of oral sensory tools. Like we have the Sensi tool, for example, and if we want to get tongue lateralization, we can't say to a 1-year-old, lateralize your tongue, right? Or move your tongue to the side. So we use vibration, we use these tools to provide stimulation, to facilitate a motor skill. Whereas myofunctional therapy is very volitional, where we'll say your jaw is still, like I wrote the SMILE program, it's a myofunctional program. It's all directions that you're giving to the patient. And I think what has really gotten confusing is that this notion of if you have an orofacial myofunctional disorder, you need orofacial myofunctional therapy. And what has really sparked this, in my opinion, is the increased awareness of tongue tie or TOTs, tethered oral tissue. Mm-hmm. And yes, a baby can have tongue tie. It's a congenital anomaly. We don't ignore the tongue tie. A 1-year-old can be drinking through a straw with the tongue protruded and suckling and not using age-appropriate skills for the toddler years. But are we going to be able to do the traditional myofunctional therapy? And if I can rewind a minute, a little bit about my background, when I first started taking courses and going to IAOM conventions in the late 90s, early 2000s, they didn't even do myofunctional therapy with anyone under the age of 8.
Wow.
Was, what we were taught. You have to know the why of the program. Dr. Bob Mason, Sandra Holtzman, the Zimmermans, they used to teach us this. And it was all about volitional swallowing, volitional oral resting posture. And then in my other part of my world, in my feeding, in my speech pathology world, I was learning from the masters, Pam and Sarah and Lori and Diane and Melanie and Nina, and all these great feeding specialists, that what we do in the early years is that we mitigate, we prevent, we facilitate. So I think when one of the divides is when you have that separation, RDH versus SLP, or OT versus RDH, or SLPs and SLPs that are only doing myofunctional and they've never been trained in feeding. When that happens, you don't understand the continuum across the lifespan, right? Mm-hmm. So at 0 to 4 population, first and foremost, most critical, if a baby is born with an orofacial myofunctional disorder, what does that look like in infancy? It could be low tone, airway obstruction, tethered oral tissue. Those would be your 3, right? The trifecta. And they often occur together. So when we get that, what do we need? We need a lactation specialist. We need an IBCLC. Why? Because breastfeeding is one of the healthiest things for the orofacial complex. Linda D'Onofrio teaches us this. Catherine Watson-Jenna teaches us this. Brian Palmer teaches this. Kevin Boyd teaches this. So it's not in one field. You have lactation, dentistry, ENTs, speech pathologists, PTs, OTs, all agreeing that breastfeeding is very critical, okay? Now, not all women can breastfeed for various reasons. It can be they need to be on a special medication. They may have, something wrong medically with the breast. The baby may have such significant allergies that they can't isolate what's in the diet that's triggering GI issues, right? And that's why we have OTs and SLPs who can be feeding specialists, and a lot of SLPs and OTs. We have a lot of SLPs, OTs, and PTs alike that are very interested in infant feeding and work with newborns in the NICU, alongside with IBCLCs and the physicians and the nurses. So this increased awareness, it's great. This is what I've wanted my whole career, for people to understand what we do, to be interested in oral motor, to recognize tongue tie and how it affects people across the lifespan. However, it is important to recognize that not everybody's trained to work with babies. And if you look at the traditional myofunctional training, that IAOM course, we sat in it together, right? We spent the weekend together. Did we learn about infant function? No, that's not traditional myofunctional training. So where you're going to learn about that 0 to 3 oral motor development, that's what speech pathologists are studying. That's what IBCLCs are studying. And that's what OTs are studying. And I'm happy to see that RDHs and PTs as well are really starting to look at, what are the red flags. Certainly RDHs are doing early infant healthcare screenings, right? And you could be very paramount in seeing, wait, something is wrong here, and we got to get this child to a specialist. And PTs are often working in 0 to 3 in early intervention. And if they're seeing babies that have torticollis and tension through the body and difficulties with feeding, even if they're not themselves working with a lot of TOTs patients, we want them to have the awareness to refer. So there's still a team of professionals from 0 to 4 and then 4 from up. But I think that the semantics we use is very important, because what we call ourselves, or the therapy modality that we say that we're using, comes with a certain meaning behind it and a certain assumption. And my biggest concern is what I see online in all the Facebook groups is parents of infants looking for myofunctional therapists for newborns. And you know what? You may have
I get messages
also a feeding specialist, but you may not.
Exactly. I get messages every day for 1-year-olds. And it is important to say that it's important for dental hygienists to understand orofacial malfunction disorders, because we are seeing these young patients. Sometimes parents bring them when they're 6 months old to the dental office. They got their first tooth. We just want to make sure everything's good. And usually on a dental visit, we're talking about, pacifier or finger sucking, thumb sucking, or how to properly clean their teeth. Let's start talking about these things now. So it's important for dental hygienists to be able to recognize orofacial malfunctional disorders, because we see healthy kids. If a child has an issue, that's when they're going to look for a pathologist, for an OT. But in the dental office, we can catch these things early. Does that mean that a hygienist or a myofunctional therapist is going to treat these kids that really know? But if a hygienist can see these things, like Robyn just said, we can go ahead and refer to the proper specialist. It's so important for us to understand what each one of these professions does. And
yes.
When should I refer to for speech? When should I refer to an OT? When should I send this patient to an ENT? I need to know that. So that's why it's so important for us to have a team wherever you live. Go visit an IBCLC. Go visit your local dentist, NT orthodontist, and build a team and share with each other, because it's so important for us to know what each one of those specialties there, so we can help each other out to
Yes.
get a prognosis
And
of that patient.
That's such an amazing point, because you're seeing, you, as a dental hygienist, and you're getting to get in the mouth of a baby or a child that the parent may not even realize that something is wrong. So many, I'll tell you, being a school-based speech pathologist for 26 years,
Yeah.
so many parents fill out on the intake or the case history form, does your child have feeding issues? No. But then when I evaluate the child, they have a tongue thrust, they don't chew properly, they chew with their mouth open, they have bolus residue, they have a scattered bolus, they're a picky eater, they still can't drink through a straw, and they're
issues though, because you know why? Their weight's fine. They're reaching other symptoms.
Right. They don't know that there's a feeding problem, because they think of feeding, yeah, he eats and gains weight.
Mm-hmm.
So it is really important, and I really push for that in my courses, and I try to put posts on it as well. And a lot of times the pediatricians, they told me with my son, don't go to the dentist until he's 2. And when I called my dentist, I said, I don't agree with that. No, 2 is fine. I'm like, no, it's not. It's not fine at 2. Because I know. I learned from dialysis at 6 that I'm supposed to go, or my son was older by then. But I'm just saying that we have a lot of knowledgeable people that we know that's not so. And it's the same with the American Academy of Pediatrics putting out position statements that it's fine to have a pacifier or suck your thumb till you're 2-3 years old. I mean, the damage is already, and that's a perfect example, right? Because in orofacial myofunctional therapy, what are one of the things we both do as an RDH, as an SLP, as scope of practice? Habit elimination, right? But when you're working with a 2-year-old, let's say, you may see a 2-year-old to do habit elimination.
Well, I'm not. But I refer that to you.
Yeah, but some RDHs are seeing, children this young. Things vary by state and their training, but I'm seeing more and more of this. But to me, that when kids are that young, they can't participate in a formal
myofunctional therapy
habit elimination program, right? So what do I come in and do as a speech pathologist and an oral motor specialist? Well, I'm going to look at first, why are they sucking? And of course, so it's going to be a high palate, a tongue tie, low tone.
Exactly. So whenever they have these habits, there's something else going on. So
it's a symptom. It's a symptom, right? So I'm going to address the medical, and then I'm going to work on oral sensory motor function, making sure, making sure that I am addressing, are the oral motor milestones in the 0 to 3 milestones? Because if I don't help remediate it at 0 to 3, they're probably still going to end up with some myofunctional issues and orthodontic issues along the line. But I can certainly prevent it from being really significant and severe. And that's why I have, I've taught, and we've turned it into e-learning, oral facial myofunctional disorders in the 0 to 3 population, because it's more based on those oral motor norms. And what are we doing? We're doing myofascial release. We're doing Beckman oral motor. A big part of our work in 0 to 3 is jaw work and mastication. Lori Overland developed a chewing hierarchy. It's been tried and true for about 30 years. We work on that integration of the cheek muscles, the chewing, the breaking down of the food, the integration of what the tongue is supposed to be doing. We work on that strength and stability. We work on phonatory control. We're very interested in making sure all of these milestones, including the jaw tongue hierarchy of dissociation that was developed by Sarah Rosenfeld Johnson. And what that is basically about is when a baby is born, you're looking at how the jaw moves independently of the tongue and the different stages the tongue goes through. And I know when you took my class, when it came down to Savannah, I talk a lot about this in terms of when a baby's born, there's protrusion and retraction, and that's for breast and bottle feeding, right? And that's a 50-50 ratio. And the first 6 months of life, that tongue goes back to being retracted 75% of the time.
Wow.
Right away, we know when we see, a baby 7, 8, 9 months old, a year old, and their tongue is forward and out, we're already looking at a problem. We're not going to wait until that baby is 4 years old and ready for myofunctional therapy. We're going to start working on that pediatric feeding component. Next, we're going to look for the tongue lateralization, because that's what's going to help start bringing the food in and moving to the chewing surface. Then we're going to start looking for that elevation. So all the oral motor milestones that are needed for feeding and speech, to include liquids, solids, cup drinking, straw drinking, all the sounds that we have in our phonemic inventory, that's all achieved by 3. So once you get into the 3, 4 is kind of a funny age, because some kids can be ready for some simplistic myo work between 3 and 4. But usually it's 4 and up. And that's when we can start getting them more involved in a more volitional way and a more conscious way of what is your tongue supposed to be doing? What is your mouth supposed to be doing? Are your teeth together? Where do you feel the food in your mouth? And things in this area. And I think that, too often the OMDs are just ignored in the young population by the pediatricians. And then again, it's ignored in special needs populations because, they can't work on that because they can't engage in the therapy. That's why we have this whole other modality that we can use.
That is absolutely amazing. Lael just said, I see babies and toddlers as an RDH in the dental office and immediately refer to my IBCSC for early intervention, feeding specialist SLP. I can at least give them growth and development information with cups, chewing, importance, etc., without actually providing any therapies. I also have been lucky to watch what they do during appointments, so I can make these very important referrals. Exactly. So
yeah, that's awesome. That is so awesome. Yeah, absolutely. And it's a team. It's the same. I get patients in my office and I can identify issues with, dental malocclusion and all kinds of different issues with the gums and everything. But that's going right to dental and RDH. Like, I can't even pretend to treat that, even if something as simple as what kind of toothpaste, this is where it's hard, because in this arena, we take a lot of interdisciplinary classes and you come out with a lot of knowledge, and sometimes it's hard when you know something, like I have to go, I really can't give that advice because it's not in my wheelhouse, but I think it's really important, like you said, who do we go to? It's even with TOTs care, because it's a continuum across the lifespan. And I think that TOTs in itself has really blurred the lines of, scope of practice and what orofacial myofunctional therapy truly is, because wound management isn't myofunctional therapy. And, feeding therapy, neuromuscular reeducation, certainly oral phase dysphagia is a part of myofunctional therapy. But as soon as you start getting into issues with the actual swallowing function or the airway or GI issues, constipation issues, rumination issues, that's when we really need, the feeding specialist team, because the members of that team can vary a little bit. In looking a lot at GI and ENT specialists and nutrition, it's overlapping, but there are definitely variations even with like medical coding and things of that nature.
Exactly. I just want to remind everybody, if you post in the comments, I would know that you watched this live, and we're going to send you a 10% coupon for Simply Breathe, the strips that we had them last week. I don't have them with me right now. But I need to know who's watching live, so you get a 10% coupon. So just write me on the comments, and I'll go over after our live is over, and I'll go ahead and send you guys a coupon. Something else I wanted to say, we're getting ready to open the floor for a couple questions. So go ahead and come up with some questions so we can ask Robyn before she leaves. But I have one more. I have two more. The next one is, what type of feeding issues do you usually see in children with orofacial functional disorders? We talked a little bit.
That's a great question. We see a myriad of issues, but the big ones that come to mind are, one, we have issues with progressing along the normal timeline of transitioning utensils and transitioning textures. So what this means is, when do these patients get referred to my office? One example would be breastfeeding is going okay because mom is, well, I say going okay, that baby's gaining weight, but mom's in pain, mom's nipples are bleeding, but they're like trucking through it. And now mom has to go back to work and can't get the baby on the bottle because the bottle heat doesn't conform to the mouth, and they seek feeding help. Or they've been able to manage breast bottle and purees, but solids are introduced and they're gagging, throwing up because, let's say they have a tongue tie, they can't mobilize the bolus to the chewing surface and it's getting stuck and they're having issues. As these problems manifest, we see issues with self-limited diets and picky eating habits, where we have to use a sensory motor approach or something like an SOS approach to feeding, where we're combining sensory motor integration within a behavioral model to explore food choices, to strive for adequate nutrition. We also see a lot of inept or immature eating patterns. So patients will come into me with a primary concern is something's wrong because my kid's a really messy eater. He's always, eating too fast or overstuffing, and he has a lot of digestive issues. Like sometimes he gets up in the middle of the night and vomits, and the food isn't even chewed. And then I'm discovering that, there's a very high palate, or there's issues with the dentition and or tethered oral tissue. And, these kids were compensating, even adults that I've seen over long periods of time that have a lifelong, like I feel like things get stuck in my throat and I can't swallow them properly. And digestion starts in the mouth. So if you're not masticating your food properly and you're swallowing food that doesn't have enough of the saliva to break down the enzymes, or the bolus isn't chewed to a point where it's soft enough for the stomach to digest it, it's going to cause discomfort, or it's going to come up, or it's going to cause sluggishness in the digestive system. So that's something when we do, just like when you get myofunctional training, we learn a lot about the muscles, the nerves, how the teeth are supposed to align, what the palate's supposed to look like. We learn a lot as feeding specialists about the esophagus, the pharynx, going all the way down into the stomach and the complete digestive system and how it all works together. So we do the muscles and the nerves too, but we're doing a lot with, and the airway as well, because obviously aspiration and choking is certainly a risk in feeding disorders. Do you want to read some of these? How do we? From mute, Renata. Renata, I can't hear you.
I'm sorry, can you hear me now?
Yes.
I am so sorry, I'm talking about myself. So we do have one question over here. It says, how do we know what courses a therapist has taken? Is there a database, or what credentials are recommended?
This is a phenomenal question, and one that I'm also passionate about. Mary Billings and I just did a webinar, and we were talking about this for a good length of time. Every professional organization, I'm going to speak as a speech pathologist because that's what I know the most about, and you can speak about your organization. But as a speech pathologist, we have a national organization called ASHA, the American Speech Language and Hearing Association, and they credential us, okay? And credentialing bodies really have a stringent set of rules to adhere to that's actually in place by the federal government. So when you're credentialed in something, it usually means that you've had to complete a certain amount of coursework, you've had to be evaluated, and it's sort of like a matriculation. And you also have to maintain continuing education after that, right? And then the organization that credentials you, they have to have a board. They have to have a non-biased board that's meeting, that's developing ethics, that's developing what your scope is. So ASHA gives us our certificate of clinical competence. And then to be able to practice, that's not enough because we have to be licensed in the state where we practice. And that licensing board is who regulates us. So if I'm not keeping up with my continuing education, if I'm not being compliant with privacy laws, if I'm doing things that my license doesn't say I can do, like if all of a sudden I decide to start, administering vitamins out of my speech pathology office as a speech pathologist, I'm not licensed to do that, so I could be sanctioned. The International Association of Orofacial Myology, we are certified orofacial myologists. They meet those credentials as well because they have a board of directors, they're nonprofit. We have to take a coursework, and then we are evaluated in a written format, in an on-site format. And once we receive our certification, we have to continue with taking coursework and earning those hours. And we also have to abide by the bylaws or the ethical obligations of the organization. With that being said, there's a lot of things that pop up. And what Mary and I were talking about is it's not okay to just like kind of throw some letters after your name. And what I always recommend that parents do is check the credentials, people ask me this and I have no problem explaining what it is and where they can get the information. And, as a parent looking, I would be looking for where did those letters come from, and is that truly an accredited organization per se? Because a lot of things can look, professional, and it's tricky because orofacial myofunctional therapy is in its own separate profession. It's a treatment modality, and right now, only RDHs and SLPs, speech pathologists, and registered dental hygienists have this formally listed in their national scope of practice. that doesn't mean that a variety of professionals do not treat the various aspects of orofacial malfunctional disorders. Like a PT can treat TMJ and an OT can treat torticollis. All of these things overlap. But what we want to watch out for perhaps is other professions or unlicensed professionals that kind of add that title to their name when they don't necessarily have a certification from a credentialing body. And people have different opinions on this, and we can share our opinions. But I will say that, I practiced orofacial myofunctional therapy as a speech pathologist for 23 years before I went and became a COM. I didn't need a COM per se because I had a lot of training. And in my speech pathology license and in my scope of practice on the national level, it's within my scope, but I felt it was a higher standard and it was going to teach me a lot. And I was going to learn from instructors that had a lot to offer me. And I wanted that like-mindedness of other people in the organization, of ethics, and providing patients with the absolute best care.
Definitely.
And I really enjoyed it. And I meet people like Renata and all the other wonderful people in our organization that I learn from all the time. Just because you teach doesn't mean that you're not still learning. It's so important.
We're all still learning. We had Lorraine Frey yesterday on our clubhouse. We had such a good talk, but we talked a lot about, should we get the COM, should we not? And my sense is I had no idea how much I was going to learn with that written exam. It was super difficult. It's not as difficult as it used to be. It used to be 10 times worse from what we hear.
I heard. I don't know how much worse, but
right?
Even for me, who was very seasoned at the time of taking it. But you know what I loved about it? Because there's a lot of on Facebook the impulse to not research and just ask a question. Is this a tongue tie? I got this patient. I don't know what to do. What helps us learn is the research. Why do you think when you go to college or graduate school, they make you write a paper? Because they want you to go through the process. We can't just answer people's questions all the time. And it's especially important when we talk about evidence-based practices. If you just tell me what to do, I don't understand necessarily why I'm doing it. And I know when you were taking your test, the speech questions, become challenging, just like the dental questions were for me. And that's the beauty of it. I'm not going to answer the question for you, but I'm going to give you all the resources you need, because that reading and that investigation is going to make you so much better at what you do. It certainly makes me better at what I do. I'm a little bit of a journal nerd. Like people are reading the newspaper in the morning, I'm reading the JAMA Network. I mean, it just, I laugh. I was talking to Dr. Zaghi last week, and I told him that I know he wrote a study before he published it, because he's like, oh, look at the study. I'm like, oh, I read that, and I already put the whole thing in my class, and I talk about it because I think it's really important,
especially in a field like therapy, that it's been here for a long time, but now in the past 5-10 years, it kind of has exploded. So the more professionals that are getting involved, the more professionals and parents that are asking about this, the more research we do need in this field to keep doing what we're doing.
Right. And it's important because, and it goes back to the original questions that you wanted to ask me. What's the difference between feeding and myofunctional therapy? And that's why I finally said, you know what? It's not enough anymore to talk about it on Facebook, to put it in a blog. I'm going to really have to sit down and do a systemic literature review to show, hey guys, look, I get it. We're seeing issues in young children. But guess what? We've been treating this. This has been around since like the 1900s. This has never been ignored. we don't want to rebrand things. We don't want to have something that's already established and call it a new name. We want to learn from each other and the whys and what the research is saying. And you're not going to find studies anywhere on myofunctional therapy with infants because it doesn't exist. You know, what you're going to find is how craniofacial anomalies and disruptions to the orofacial complex can impact newborns all the way through their toddler years, and what's going to manifest if we don't take care of it. So it's important to delineate, this is diagnosis and these are treatment modalities.
Perfect. I know that we are getting close to our time. We are going to cut a little bit shorter today, guys. But does anybody have any questions? And I know that we have a little bit of a delay, so they're not going to listen to what I'm saying until a couple minutes from now.
Okay, so we'll wait.
If we have one last question, just let us know. You can post it in the comments. We'll bring it up. And while we're waiting, I'll go ahead and tell you guys about our next week. We have Clubhouse every Tuesday and Thursday at 8 p.m. Eastern Standard Time. On Tuesday, we have all the ladies that were talking about gut health come back. These are fantastic women who are professionals in their industries and were teaching us everything about gut health. On Thursday, I do not want to say who's coming on Thursday, but it's somebody. It's actually two different people from Australia. You guys can take your guesses. And then on Friday, we have another speech pathologist who also does breastfeeding. I'm not going to say who it is. You guys can send me a DM if you'd like to guess who the speaker is for a prize. And
I know, so I'm not allowed to say it.
I know, you didn't say it. I mean, I just gave it away, so come on. You guys got to know who it is now. If you guys are not part of our Facebook group, it's a private group. We try to keep it mostly professional. Airway Circle. You got to answer the questions, and please join us. Over there, we post the clubhouses and the Facebook lives, and we post research articles, and we talk and we laugh. And it has become a really fun, cool community. I mean, we have amazing people in the industry ask questions, and we're also looking for referrals. You know, I need somebody in this place. Does anybody know a professional, an ENT, an orthodontist, a myofunctional therapist in this city? And everybody's been super, super helpful over there. All right, last question, guys. Robyn, if you had to pick one course to learn more in this space, what would you pick? Well, we need to tell us about your course. Let's just talk about your course. How about that?
Well, listen, I love teaching, but I learned my foundation from the real masters, right? So, it would help to know when you talk about this space, are you talking about feeding therapy or myofunctional therapy?
I'm not sure either.
Because I will say this, I think every good therapist, whether it's an OT or SLP doing feeding, or an RDH who is going on their path to do myofunctional therapy, I think everyone needs a solid 0 to 3 mouth development course, because if you don't know normal, how can you recognize abnormal? So not because she's one of my good friends, but because she was one of my first mentors, and I will still say to this day, the best CE course that I've ever taken is a sensory motor approach to feeding by Lori Overland. It's just brilliant. It helps you understand normal mouth development, motor planning, how it's related to feeding and speech, how the sensory system impacts your motor system. And Lori is coming from the background of speech pathology, but she's also neurodevelopmental training certified. She also is a certified lactation counselor, and soon she will be an IBCLC.
Oh my Lord.
So, whether you're a hygienist that wants to be able to recognize problems to refer out, or you're an SLP or an OT or a PT. To me, it's a core foundation. It should be in graduate school or undergraduate school from everybody.
That is amazing. Can you tell us before you go? I cut you off. Go ahead.
No, go ahead. It's fine.
Because I know that you have to go. I don't want to keep you here longer.
It's okay. No, I'm good. I'm good.
But I do want you to tell everybody about your courses and where can they find you? Where can they learn from you? Like the course that I took whenever you came, to Savannah was absolutely fantastic. If anybody wants to take one of your courses, where do they go?
Okay. I just want to answer this question quick. If you know an SLP that provides care to that young group, where would we refer them? That would be Lori Overland's training. Another great training for them would be Diane Barr, who's also wonderful, and Nina Johansson's AEIOU approach to feeding. And Melanie Poddick is phenomenal as well. So those are really good speech pathologists who teach feeding. And then in the OT world, we have Marcia Dunn Klein, who's fabulous and also has a book on pre-feeding.
Awesome.
As far as my courses, right now I teach 2 main courses, but I have something exciting coming up. So with my partner, Lori Overland, we teach a functional assessment and remediation of tethered oral tissue. Right now, they are all virtual live. We do have one coming up June 5th and 6th. This was a 1-day class, and everyone said we want more. So we've now divided it into 1 day of assessment and 1 day of treatment. So you can take either or you can take it all together. And they do give you a package deal when you take both days. I teach a course on my SMILE program. SMILE is Systematic Intervention for Lingual Elevation. And it is a course from a speech pathologist's point of view of treating complex articulation problems with myofunctional therapy. But this course is really based off the program, which is in print. It goes together. Starting this summer, I'll be launching a new orofacial myology class. So look for that in July. And we have a lot of great stuff coming up. We just did our big OMDs deconstructed. We will be having a series of our TalkTools instructors. We practice what we teach. And this will be a combination of both oral motor, feeding, myofunctional. That'll be in June. And stay tuned for late summer. We also will be having a talk symposium with some guest speakers, and we will be bringing in all the top experts from everywhere. So there's something going on. You can catch me. We'll be at speaking for the AAPMD, Lori and myself, on the variations of wound care on neuromuscular re-education for TOTs. You may see me upcoming and doing some work on some webinars, but yeah, I keep busy.
I know it was hard to get you, so thank you so much for being here. I really appreciate your time and your knowledge and your sharing with us. I would like to ask everybody listening, if you guys know a speech pathologist or a dental hygienist or a group or moms who you would think would benefit from listening to what we talked about today, please share this video, share with them. We are doing these free live talks. They're not real lectures or courses. They're just, talks. Please share them with your friends and your family and your colleagues. We do want to spread the word as much as we can to as many people as we can reach. That's the whole goal of Ori Circle. So, Robyn, thank you so much for being
Thank you, and I'm so honored that you had me, and I'm so proud of everything that you're doing. You're a wonderful RDH and an advocate for many things like supporting breastfeeding. And if you're not following her on Instagram, she's just got a beautiful, not only is it a lot of good information, but it's just so visually appealing and beautifully done, which is great because we want that eye-catching professional these messages out there to bring awareness, because the more awareness we have, the more help that people can get.
Definitely. Well, thank you so much, guys. Have a wonderful night, and we'll see you on Tuesday on Clubhouse. Bye-bye, everybody.
Bye. Thank you.